Congenital hypothyroidism is super common, and if you work with newborn babies at all, you are definitely going to end up seeing it in your career. It affects about 1 in 2,000 babies, and if untreated, its effects can be devastating on the development. But if congenital hypothyroidism is caught early and treated adequately, then basically those kids are going to be unaffected. So it's super important to catch and to treat neonatal hypothyroidism in any baby who may have it. Hello, I'm Dr. Tala and I've been a neonatologist for 16 years now, and today we're going to talk about hypothyroidism or low thyroid levels in babies. Make sure you stick around to the end so that you can get your homework assignments. Mostly, I'm going to go over the report that was published in 2023 by the AAP, and it was published in Pediatrics by Rose et al., and it just covers the screening and the management of congenital hypothyroidism. We'll also have a few other references, and they're all listed below. So this is what we're going to be covering today. 1, the function and regulation of the thyroid gland. 2, causes of hypothyroidism. 3, clinical manifestations of hypothyroidism. 4, the diagnosis, including the importance of newborn screening. 5, the treatment. And 6, the outcomes of infants with hypothyroidism. 1, let's start with a function and regulation of the thyroid gland. So the thyroid gland starts developing in babies in the early first trimester. And basically it starts developing at the base of the tongue and then slowly tracks down so that it ends up in the anterior neck region, which is where our thyroid gland is now. The primary function of the thyroid gland, as you all know, is to produce and secrete the thyroid hormones. Thyroxine, or T4, is the main hormone, but really this is considered a prohormone because the majority of it gets converted in the periphery, in the rest of the body, to T3, or triiodothyronine. Most of the T4 and T3 hormones, which are circulating through blood, are bound to proteins, including T4 binding globulin. It's only the free T4 and the free T3, the unbound thyroid hormone, that's able to enter the cells and exert its effects. So when we're following babies with hypothyroidism during screening or during treatment, we usually follow the free T4 because that's what the baby cells are actually seeing. So what tells the thyroid gland how much thyroid hormone it needs to produce? Well, interestingly, the brain does. And you probably know a lot of this, but I know that you've all really missed my art. So specifically in the brain, the anterior pituitary secretes thyroid stimulating hormone. That thyroid stimulating hormone then travels down in the blood to the thyroid gland and stimulates the thyroid gland to produce more thyroid hormone. What's so amazing about this is that it's all on a feedback loop. So for example, if the thyroid gland is not producing enough thyroid and the thyroid levels are really low, then the anterior pituitary recognizes that and starts secreting higher and higher levels of thyroid stimulating hormone, or TSH. The opposite is also true. If the thyroid gland is pumping out loads of thyroid hormone, then it will go back to the anterior pituitary and tell the anterior pituitary, stop, just stop producing as much. So the TSH level, if the free T4 is really high because of that reason, the TSH level will be low. The TSH and the thyroid hormones are controlled at an even higher level by the hypothalamus, obviously also in the brain, which releases thyrotropin releasing hormone. We don't follow that one as much clinically, but I just want you to know there's also a feedback loop on the TRH as well. If a baby does have hypothyroidism, then generally we can kind of figure out where the problem is based on the TSH and the free T4 levels. If the free T4 is really low and the TSH is really high, then the problem is probably in the thyroid gland. If the TSH is super low and the free T4 is really low, then maybe it's a problem in the pituitary. Make sure you understand this. So what do the thyroid hormones actually do? Well, anybody who's studied medicine at all knows all the various symptoms that we've had to learn in patients with hypothyroidism. So fatigue, coldness, low resting heart rate, dryness of the skin, constipation. It obviously affects many, many different systems. And we'll talk a little bit more about the symptoms of hypothyroidism in a bit, but just realize for a hormone to be affecting so many different symptoms, it must be very important in lots of different areas of the body. But there's one really important thing that you have to realize. There's a big difference in developing hypothyroidism as an adult versus being born with it. And that is that as babies are growing, part of that neurodevelopmental and physical growth is dependent on the thyroid hormone. So if an adult develops hypothyroidism, it's not going to affect them cognitively. I mean, they'll be a bit slower and more tired. But if babies have hypothyroidism, then that could seriously affect their neurodevelopmental outcomes. The horrible term cretinism used to be used to describe babies with severe physical and mental deficiencies secondary to hypothyroidism at birth or during pregnancy. 2. So what causes hypothyroidism? And we kind of went over this a little bit before. The vast majority of hypothyroidism is because there's an abnormality in the thyroid actually producing the hormones. Only a very small percentage of hypothyroidism is secondary to an abnormality in the pituitary. So I'm mostly going to concentrate on abnormalities in the thyroid. So just talking about the thyroid gland, there are 2 major causes of hypothyroidism. The first one is when the thyroid gland wasn't made at all, or it was just made very abnormally. And this is called thyroid dysgenesis. The second problem is if the thyroid gland is actually there, but it has an issue, maybe with the enzymes or whatever, in actually producing the hormones. Most of these issues are caused by dysgenesis, where the thyroid gland just isn't made right, or it's small, or it didn't migrate all the way down to the anterior neck, and so it isn't functioning right. That's where the term lingual thyroid comes from. So it's still kind of at the base of the tongue. And most of the time, thyroid dysgenesis is just completely random, just bad luck during pregnancy and growth of the baby. There are a few genetic cases of thyroid dysgenesis, but this only makes up about 2 to 5% of the cases. Interestingly, the number of babies who have a normal thyroid but just aren't producing enough thyroid hormone has increased considerably in the last 20 years. And in this case, it's a lot more likely to have a genetic origin. Also, other factors could inhibit the baby's ability to produce thyroid hormone, just even transiently. So, for example, if the mother has hypothyroidism, so the mother has high thyroid levels, and she's on medication to treat it, so for example, methimazole or propylthiouracil, then those medications can cross through the placenta and actually transiently inhibit thyroid production of the babies. And this can decrease the baby's thyroid production for 7 to 10 days. Or the mother has Graves' disease and has antibodies to the TSH receptor. These antibodies are usually IgG, so we know they can cross the placenta and they can go to the baby's TSH and actually block TSH release. If a baby is born to a mother with Graves' disease, then those antibodies may stick around for about 6 months. In this case, the TSH obviously will be low, and therefore the free T4 will also be low. Internationally, iodine deficiency is a pretty common cause of hypothyroidism and probably the most preventable cause of intellectual delays. In the US, it's a lot less likely, but still, pregnant mothers are encouraged to take a prenatal vitamin with iodine in it. As you all know, iodine is needed to actually produce the thyroid hormone. So obviously, if you're lacking iodine, then the thyroid gland isn't able to produce the thyroid hormone that it needs to. So just to really reiterate this point, if there is an abnormality with the thyroid gland, which we already said is the vast majority of cases of hypothyroidism, whether it's dysgenesis, so the thyroid gland wasn't made normally, or whether there's an issue with actually producing the hormone, then what are we going to see? We're going to see a low level of free T4. And then what's going to happen here? Because of the feedback loop, the anterior pituitary is going to see this low level of free T4 and start spitting out as much TSH as possible. So what you would see classically is a low free T4 and a very elevated TSH level. And I'm going to reiterate this again, sometimes, very rarely, the cause of the hypothyroidism is central. And when we say central in medicine, basically we mean brain or kind of middle of the body. So here it would be an abnormality in the pituitary or the hypothalamus. Again, this is so rare, but still, I'm just going to say 3 things about this. The first one is it's a lot more common for the pituitary to have an issue with releasing TSH than for the hypothalamus. The second thing is here, if you tested the levels, you would see a really low TSH level and a really low free T4 level. So this is kind of a clue that it could be central. A low free T4, and then instead of this being elevated, the TSH is actually really low. And the third thing is, and honestly, this is probably the most important clinically, the anterior pituitary doesn't just release TSH, it also releases a bunch of other hormones. For example, growth hormones, gonadotropins, adrenocorticotropins. So generally, if there is an abnormality with the anterior pituitary, you won't just have a low TSH, you'll also have low growth hormone levels. The babies may present with hypoglycemia or micropenis and a bunch of other symptoms. So it would be unusual to just have isolated low TSH from the anterior pituitary. 3. What about clinical manifestations of hypothyroidism? Well, like we already said, having a low thyroid level affects many systems in the body, but there are a few things that you specifically have to know, the symptoms in neonates. In babies, like a lot of diseases they have, the symptoms might initially be subtle and very non-specific. So you really have to be aware of the fact that hypothyroidism should be on your list of differentials. And a lot of babies born with hypothyroidism initially might not have any symptoms at all, which is why the newborn screen is so important, and we'll come back to that in a minute. The 3 most common symptoms that we would see, though, would be jaundice, poor feeds, and hypoglycemia. So remember those: jaundice, poor feeds, and hypoglycemia. Other symptoms may be more similar to adults. So we could have constipation or bradycardia, or the baby is cold, or maybe baby's a little bit edematous. Then there are classical symptoms associated with really severe congenital hypothyroidism. And by the way, people that write tests absolutely love these symptoms, so make sure that you know them. The first one is macroglossia, or a really enlarged tongue. The second one, which we do actually see, is an enlarged fontanelle, specifically the posterior fontanelle still being open and above 0.5 centimeters is one thing that you can kind of get tested on and you should be examining. And the third one is an umbilical hernia, which obviously we see in a lot of babies anyway. You won't necessarily notice this in the newborn period, but like we said, in newborns, thyroid hormone also affects growth and development. So if a baby is lagging, then that might also be a sign of hypothyroidism. 4, diagnosis. So obviously we've kind of touched on this a lot, but obviously if you have any even slightly concerning symptoms, then make sure that you do actually check thyroid levels. However, as we said, a lot of those symptoms can be really subtle or not there at all, which is why we are so reliant on the newborn screen to make the diagnosis of hypothyroidism. Universal newborn screening includes testing for hypothyroidism in the US as well as in most developed countries in the world. And in the US, at least, we should be getting that screening between 1 to 7 days of life. Every state does something pretty different. If the baby is sick or premature or particularly high risk, for example, babies with Down syndrome, go watch the video on Down syndrome babies, then that test has to be repeated at a couple of weeks of life or 36 weeks corrected gestational age. The AAP has different guidelines. Honestly, most states in the US actually get that second newborn screen anyway. Most state labs are checking the TSH level because if you think about it, that's going to be more sensitive in diagnosing hypothyroidism than a free T4 level. Because if the free T4 is just a little bit low, then the TSH will carry on cranking itself up, trying to squeeze out as much thyroid hormone from the thyroid gland. And maybe a really high TSH level will get just to normal levels of the free T4. But that high level of TSH is going to indicate that something is going on here. Some states do actually check the T4 level, but there's usually some sort of reflex stages. So a lot of places, if the TSH level is high, they'll check a T4. If there are abnormalities in the T4, they'll go check the TSH, or they do them at the same time. I just want to add something here. Anybody that's worked in the NICU or with newborns has had false positive newborn screen results. Obviously, it's a screening test. We don't want to miss anybody. So there are going to be, by definition, higher rates of false positives. One of the things that can result in a false positive screen, because it affects the production of the thyroid hormone, are certain medications. And those medications include heparin, dopamine, fatty acids, Lasix or furosemide. So if your baby in the unit is on any of those drugs, there could be a higher chance of getting a positive newborn screen, which is a false positive. Another thing I want to add, and I've mentioned this previously on a previous newborn screen video, it is so important that that loop is closed. If the newborn screen is sent and the thyroid level is elevated and nobody's following up on that result, then you might as well not send it. So it's important that there's a system in place where the lab calls the primary care provider or the NICU or whatever to make sure that we are doing something about it. It's really important that none of these test results fall through the cracks. 5. So how do we manage infants with congenital hypothyroidism? Well, in the paper that I already mentioned, the AAP goes through a beautiful algorithm of how exactly we should treat babies with an abnormal newborn screen, or obviously with symptoms that ended up having an elevated TSH. If the newborn screen comes back abnormal and there's a risk of hypothyroidism, then preferably within 24 hours, you should be sending your own TSH and free T4. Some state labs actually release the level of TSH in the newborn screen. And the AAP has an algorithm based on what that level of TSH is in the newborn screen. If the newborn screen comes back with a TSH level above 40 milli international units per liter, then you should immediately start some thyroid medication, even before you get your results back. So obviously, if you get your results back and it's still above 40, then obviously you should be continuing that medication. If, like I said, the state releases the TSH level and it's less than 40, then you don't automatically have to start the medications. But if you send your own sample and the TSH level is above 20, then you should be starting medications. So this is what you have to realize. If you are sending your own TSH and free T4 and the TSH is above 20, then you should be starting medications for sure. The AAP recommends that all treatment and follow-up and everything is obviously done in conjunction with a pediatric endocrinologist. They're going to end up following these babies anyway in the future. Like we said earlier, we should also be following the free T4. And if you look at the algorithm, it wants you to get the TSH and the free T4 as well, because there are situations where the TSH might be elevated, but it's encouraging the thyroid enough to produce enough hormone level so the free T4 could still be normal. If this is the case, then the least you should be doing is at least following those labs in the future to make sure that the baby doesn't end up truly being hypothyroid. According to the algorithm, the AAP also describes different situations. For example, if the TSH level is just staying between 5 and 10, but the free T4 is normal, what do you do at that point? Well, their answer is just make sure that you're following with a pediatric endocrinologist. The important thing is you really don't want anything falling through the cracks. So if in doubt, at least make sure that you're following the TSH and the free T4. Another really important part, obviously, of diagnosing babies and treating babies with hypothyroidism is getting a really good physical exam and a history. So in the history, figure out, is there anybody else in the family with hypothyroidism? So you might be thinking there's a genetic component. Is the mother on any thyroid medications? Is it possible that the mother has Graves' disease even if she hasn't actually been diagnosed with it yet, and there are actually antibodies floating around her system too? Babies don't really need imaging or anything of the thyroid gland even after the diagnosis, but some people argue that if you do an ultrasound and you see that the thyroid gland is completely missing, or there's just dysgenesis, or it's the back of the tongue or whatever, then there's an extremely low likelihood that this baby is going to end up producing thyroid hormone. So it's much more likely that the baby will be on thyroid hormone for life. Versus the thyroid gland is there and maybe it's just some transient issue with actually producing the hormone. And this probably goes without saying, but I'm going to say it anyway. If it's a central cause of hypothyroidism, then obviously you're worried about some abnormality in the brain. If it's the pituitary or the hypothalamus that isn't actually stimulating the thyroid gland, then you should probably be getting an MRI of the brain just to make sure that there aren't any other abnormalities. Then, as you all know, if you've chosen to treat hypothyroidism, then you treat it with levothyroxine, which is the thyroid hormone basically, and it can be given IV or PO. Generally, we start, and this is what the AAP recommends, at 10 to 15 micrograms per kilo per day. This is actually a much higher dose than the baby will probably end up needing, but to aid future development, we want to try to correct the TSH and the free T4 as quickly as possible. Our goal, if it genuinely is true congenital hypothyroidism, is to start thyroid hormones within 2 weeks. So we've got 2 weeks to make this diagnosis. And then we want the labs normalized by 2 to 4 weeks. And again, to emphasize this again, the later the thyroid hormone is started, the higher the chance that there are going to be severe neurocognitive delays. So time really is of the essence here. After the medication is started, then you should be following the TSH and the free T4. Obviously, we'd be doing this in the NICU, or if the patient has been discharged, pediatric endocrinology should be doing it. The TSH should be completely normalized on the medication, and the free T4 should be kind of at the upper limit of normal. Often, we're dropping the dose severely after the TSH and the free T4 have normalized. So initially, we should be checking every 1 to 2 weeks until everything's normalized, and then once it's normalized, checking at least the levels at least once a month for the first 6 months. It's very important when we're sending babies home from the NICU that have been put on thyroid medication in the NICU that they get excellent follow-up with a pediatric endocrinologist or somebody who feels very confident about making sure that these babies are going to be followed carefully. 6, what about outcomes of infants with congenital hypothyroidism? Well, the newborn screen has greatly improved the neurodevelopmental outcomes of babies with hypothyroidism because it means that we've been able to catch those babies much sooner. If the diagnosis is made early and the TSH level is normalized by 4 to 6 weeks of life, and obviously then the baby is kept on the correct thyroid medication, then those babies should grow up and have completely normal neurocognitive function. Having said that, some studies have noted that adults that have had severe congenital hypothyroidism may have some mild deficits in memory, verbal, and attention skills. The other question that parents always want to know is how long is the baby going to have to be on the thyroid medications? Like we already said, this really depends on the cause of the hypothyroidism. If the baby has low thyroidism just because the mother has Graves' disease, then obviously it's not going to be for life. Whereas if there truly is thyroid dysgenesis, so the thyroid gland is missing or it's really small or still at the base of the tongue or whatever, then much more likely the baby is going to have to be on thyroid medication for life. Generally, babies are retested at about 3 years of age, and if it looks like their thyroid gland is functioning normally at that point, then they're taken off the medications. Okay, before we finish, I've got a little homework assignment for you. So the first one is name 5 symptoms of hypothyroidism. The second one is what lab values would you expect to see in a baby with a small ectopic thyroid gland? And the third one is, why should we be starting a very high dose of the thyroid medication at 2 weeks of life? or by 2 weeks of life. Okay, I hope you learned something. If you want the summary of this video, then go subscribe to our newsletter. If you've reached this far, then please like this video and subscribe if you're interested in neonatal educational content. Thank you so much for being here.